let's get on with this show. We are so grateful that Dr. Athanassious could make it here tonight to talk to you directly. So I'll hand the screen presenter role over to Dr. Athanassious, and let's welcome him. Thank you, Dr. Athanassious.
All right, thank you for everyone joining, and thank you for allowing me to have dinner with all of you tonight. So let's go ahead and get everything started here. Okay, so we are going to talk about spine surgery and spine health. We do focus on minimally invasive spine surgery when it's appropriate. Some cases are not minimally invasive cases, but the majority are, and certainly the majority can be taken care of with minimal damage to soft tissues. So we talked a little bit about myself. We can forego it. I do have training in orthopedic procedures and went on to complete a fellowship in spine surgery. In terms of the spine, there are three separate parts of the spine. Two of them are mobile and one of them is more fixed. We have three curves in our spine, which are major curves that allow us to have a global spine balance. We have cervical the portion, the thoracic portion, and the lumbar portion. The cervical is what we know as the neck. The thoracic is the chest cavity, and the lumbar is the lower back. The cervical and lumbar portions are the portions that most commonly give people pain, develop arthritis, and are the ones that are most commonly treated. The thoracic portion is the one that most commonly is fixed, and more often than not does develop compression fractures and fractures of osteoporosis. So the vertebral column is made up of these three segments: 7 cervical bones, 12 thoracic bones, and 5 lumbar bones. We have the sacrum, which is fused, and the coccyx, which is the tailbone. Here, this is just looking at the spine from the side, and here we see those 3 major curvatures that give an overall neutral spinal alignment. And we have the spine here from a front back view, where you can see the neck is here, the thoracic spine is here, and the rib cage would be radiating out from here, and the lower back, sacrum, and the tailbone. So we divide up spinal pain in different ways. Disease that affects the nerve roots, which are the branches off of the spinal cord and the spinal column, and a disease which causes compression on the spinal cord. The first one we'll talk about is radiculopathy, which is compression of the nerve roots about the spine. So the presentation of a patient will be pain, deep aching. Patients can describe it as electric, stabbing, paresthesia, numbness, tingling, weakness. A person can have a deficit, and when we say that it's a focal motor deficit, it means that it's a deficit of one muscle group that attaches to one nerve unit. So when I'm examining patients, I use that to try to correlate, does what we're seeing on the MRI go along with the patient's history and what's happening with the physical examination? And when all three of those things line up, that allows us to predict that this is indeed what's causing our patient's pain. And it allows me to make a better assessment as how to treat it, whether it's non-surgical or by surgical means. This is a dermatomal map. So our body does thankfully follow a map of where the nerves go and where does our sensation go. So for instance, the C6 nerve here gives us sensation over the top of the shoulder all the way down to the thumb. And when this nerve root is irritated, that's the way that we explain our pain. Patients will come in and say, it hurts over my neck, radiates down over my shoulder, and goes to my thumb. And this allows me, once again, to know where to look on X-ray or MRI or CT scan to see, is there an effect of the C6 nerve in these regions? This is once again reviewing that not only does a C5 nerve give sensation, it also will control the deltoid muscles, which are the muscles over the shoulder here. This allows us to move the arm forward, move the arm out. And a patient may come in complaining of pain over the C5 region and say, you know, my shoulder feels weak. And once again, that would prompt me to look at the x-rays, MRI or CT scan to physically examine the deltoid muscle group and see, does this all correlate together in order for us to determine the pain generator and where's the disease process coming from. The C6 nerve is similar in that it also goes to different motor units, very specific motor units. It also has a dermatomal or sensory distribution that we can rely upon to try to evaluate a patient. The C7 is very similar to this as well. And C8 is similar to this as well. The next area where a nerve can be compressed and is actually more serious is actually on the spinal cord. So the spinal cord travels all the way from the brain all the way to around the L1, L2 level, which is in the lower back region. The L1, L2 level is just above the hips by a few inches or centimeters. And when a nerve is compressed, this is of course bothersome, can cause muscular problems, but it's not as dangerous or as permanent as if the spinal cord becomes compressed. So here we have an MRI which shows the spinal cord, which is here, and you can see this large disc herniation, which is compressing on the spinal cord. This is occurring at the C4, C5 level, and this can cause a patient to have a problem with control of function of the hands and control of function of the legs. A patient may come in saying they're dropping objects, their handwriting is changing. They also may say that they are having a problem with balance or bowel or bladder dysfunction in very extreme cases. So the thoracic region is the mid-back region. Once again, this is the non-mobile segment of the spine. This can also develop areas with compression fractures in patients that are osteoporotic. And oftentimes, disc herniations don't come as often here because the thoracic spine is stabilized from the front by the ribs. The lumbar region is the lower back region. This is the region that has a lot of pathology. A lot of patients come in complaining of issues with their lower back. And this is because, once again, just like the cervical spine, it is mobile. And when there's lots of mobility, there is a chance for instability. There's a chance for disc herniation or compression. And patients come in and do complain of issues here. The lumbar region is consisting of 5 bones, L1 through L5, and it also does include the sacrum area here. So you can see that the L5S1 level also has an issue. And the lower down that we are, the more common disease occurs. So L4, L5, and L5S1 are the most common regions where patients have arthritic disease or what we call degenerative disc disease. And as we see here, there are different portions of the anatomy of the spine: the pedicle, the facet joint, the lamina, the transverse process, the lateral process as well, and also the spinous process. So we can see here certain portions, because we're just looking at the spine from front to back. This is the spinous process region. These are the transverse process. And other portions of the spine are not as evident on this view. Here we have a little different view. This is as if the patient would be laying down, and this is a cross section. So here we have the front of the spine, which is called the body, the pedicles, the spinous process, and here are the joints that also touch the spine bone above and the spine bone below. Here we have the sacrum, which is usually fused, and the coccyx, which is also fused. When someone talks about fracturing their tailbone, it's usually has to do with the coccyx bone here. The disc is made up of 2 primary regions: the nucleus pulposus, which is the center area. It's a jelly-like kind of substance. And when we speak about herniation, This is the substance which herniates into the spinal canal. The nucleus pulposus is a fibrous-like region on the outside, and this is where the tear occurs. As one ages, the water content within the nucleus pulposus and the disc decreases. And this is where we can see on an MRI, if anyone's ever looked at an MRI with their physician, someone saying that the disc is dehydrated, it's lost height, because as a person loses their water content, they lose that spongy nature and that compressibility of the disc. Height is lost in the disc, and on the MRI, it looks black on certain sequencing. The spinal nerves travel between each of the bones. So as the disc loses its height and the bones come closer together, this can cause compression on the nerves. This compression on the nerves can be described as radiculopathy, as we discussed earlier, and this can cause pain in very specific regions within the spine. So there are multiple different non-operative treatment modalities for the spine. A person could take anti-inflammatories, they could try physical therapy, they could have epidural steroid injections, they could do braces. Some patients will try acupuncture, chiropractic treatment. All of these modalities can be used for treatment of spine pain. The different sources of spine pain can be from arthritis, stenosis, which is a simple term that's used in medicine to denote narrowing. Neuroforaminal stenosis is that nerve hole narrowing. So if you remember back about 3 slides, we looked at nerve hole narrowing. That would be neuroforaminal stenosis. Degenerative disc disease is the breakdown of the disc, the dehydration of the disc, the loss of height that we spoke about. Facet disease is that enlargement of the joint that's touching the bone above and the bone below that makes up part of that nerve hole and causes compression within the nerve root. The patient can develop axial back pain, radicular pain, which is pain that radiates down a specific region, whether it be down the arms or down the legs, and can cause a loss of balance, a loss of dexterity, or weakness. When we examine patients, we'll look at different aspects, such as their subjective strength, their flexibility, their endurance, posture, and functional ability. And part of the treatment will be sometimes just education. Sometimes patients have pain. They feel that they can live with this pain, but they want to know why they're having pain and what symptoms should they look out for as dangerous symptoms in which they should seek out treatment. Some patients may want to discuss exercises that work, and there's different modalities in terms of treatment of this. So oftentimes I or the physical therapist will look at anatomy, we'll look at causative factors, body mechanics, and activity modification. Physical therapists will often focus on core stabilization, functional training, flexibility, and nerve glide exercises. So in terms of minimally invasive spine surgery, the goals are to reduce muscle trauma and thereby try to treat and try to minimize postoperative pain, decrease hospital stay, and then oftentimes with most of the procedures that we do, it is a day-stay procedure or the patient goes home the next day, and also to decrease operative blood loss. So neck surgery often involves removal of the disc or the compression on the nerves or on the spinal cord and placement of an inner body spacer between the bones, promoting opening up the space of the nerve and stabilizing the spine. Here we have a patient who has a disc herniation at the C5, C6 level. We would expect this patient to have a problem with their C6 nerve. So that would be that pain that radiates over the shoulder, down towards the thumb, and over the outside border of the arm. They may have a problem with weakness in their biceps or flexing their elbows. And this is how their MRI may look. They also, because there's compression here of the spinal cord, may say that they're having a problem with balance or dropping objects. Here, this patient had the disc removed. the nerve and the herniation removed, and they had their bone stabilized. This is a much bigger case in which there was multiple levels of compression. And this is what we refer to as an anterior cervical discectomy and fusion. In terms of back surgery, there is multiple different diseases that can occur. The patient may just have a degenerative disc in which there's loss of height between the bone. There is a bulging disc, which is causing compression within the central canal or in the nerve roots, or a herniated disc. Additionally, a patient may have a problem with osteophytes growing within the canal, which are ways of talking about arthritic bone. These can be treated initially sometimes with non-operative treatment modalities. Even in the cases of herniated discs, sometimes patients do not need surgical treatment, but having physical therapy, learning core strengthening exercises may allow them to have improvement. So lumbar stenosis, once again, speaks about that compression within the canal or within the nerve roots. Here we're comparing this patient's canal here, which is wide open, versus this one, which has compression here on either the nerve roots or the spinal cord, depending where you are on the spine. Here there's a patient that has spondylolisthesis or slippage of the spine here. And this can cause spinal stenosis, nerve root irritation. Here there's a patient with degenerative scoliosis, which is not scoliosis that we see in adolescence, but scoliosis that occurs from arthritis. This can be treated surgically and doesn't require treatment of the entire curvature, but there may be nerve root compression in certain portions of the curvature that need to be treated for relief of symptoms. In terms of opening up the space or treating the spinal stenosis, there can be openings that involve a microdecompression. And here there's a complete laminectomy, which often doesn't need to be completely done. More often, we can do what we partial microdecompression or laminotomy just to open up the space where the nerve root compression occurs. This is a day-stay procedure. And in some individuals, maybe overnight. However, the majority is a day stay, go home the same day, up and walking on the same day. Here we would go in from the back, open up the space, and relieve that area of compression. Here there's a disc herniation, so this area of the disc would be removed to open up the canal. This is once again, the way you would think about it is the front of the patient is here, the back of the patient's here. They're lying down, and we would be working from the back to move the muscle out of the way to get to the canal. Here we have a few different areas of problem. This is a spondylolisthesis. So sometimes patients have degenerative disc disease, and as their disc degenerates, they'll have a slip forward. You can see that the back of this bone does not line up with the back of this bone. This can cause compression within the canal and also within the nerve pool. There can also be stenosis in different areas. So this patient here has spondylolisthesis, which is the slip, and may have arthritis in other regions that also need to be treated. Sometimes patients will develop adjacent segment disease, which they will have a previous fusion. And in this fusion, you can see that the patient was not fused with an appropriate curvature and has developed a degenerative disc disease in the area adjacent to the previously operated level. On this most right picture, you can see degenerative scoliosis. And this is the scoliosis that we talked about occurs later in life, not necessarily occurring during adolescence. It occurs as the disc degenerates, and portions of the disc will degenerate faster, and the patient will develop a curve within the spine. So the advantages of how we do spine surgery now is we reduce the risk of complications. Oftentimes the incisions are much smaller, and it allows for us to kind of allow the patient up walking, decrease the amount of disruption of the muscles. And there can be different ways that we approach problems in the spine. It can be from a fusion approach, in which we're going in only from the back or from the posterior lateral area here. It can be from the front or from the side. And depending on each patient, what their disease process is, oftentimes we can approach the patient from different aspects in order to minimize the disruption of the muscle and the surrounding tissue and encourage the patient to be able to recover quicker and get back to their normal life. So an anterior lumbar interbody fusion is speaking about a case in which we are going in from the front. And what we would do here is we would go in, not go where the digestive system is. There's a space called the retroperitoneal space. The benefits of this is that we put in a larger cage and it is very stable. Another benefit to this is oftentimes we don't have to do much work in the back at all, so this preserves the muscles in the back. A posterior lumbar interbody fusion has to do with only going in through the back. For me, this is used in cases where we cannot go in from the front because the patient has had a very invasive procedure from the front in the past. They have a lot of scar tissue. The option is not to go in from the back. This procedure in terms of placing a cage is inferior and requires quite a bit of disruption of the posterior back musculature and can often lead to back pain. Translumbar interbody fusion is this posterior lateral kind of insertion. Once again, you can see that the cage is much smaller. Our ability to adjust and keep the patient's normal curvature is not as good as going in from the front or going in from the side. A lateral interbody fusion is another way of addressing problems. This cannot address a problem at L5-S1, but can usually address a problem anywhere from L1 to L4. This allows for a minimally invasive approach. It allows us to monitor the nerves as we're working, and allows us to put in a very big interbody spacer, which increases stability and increases the chance of fusion. So here we are kind of comparing all the different techniques. You can see here with the lateral approach or the front approach, you have a very big cage. With the posterior approach, you have smaller cages. So surgeons are effective in treating spine problems with this. However, in my hands, I do prefer these two if it is possible. So what happens after a person has a spine surgery? Well, we let them know that we want them to walk as much as possible. They may or may not have a brace to help them walk. However, the brace is often not needed. It is just for comfort and to encourage patients to walk. We also ask patients to not bend through the back, not to twist, and not to lift anything more than 10 to 25 pounds, depending on the surgery they've gone through. The main exercise is just walking. Most patients will then have physical therapy at about 4 to 6 weeks after. So this is kind of a recovery time estimate in terms of the procedure that a patient has. So if a patient has a procedure within the neck, which is the anterior cervical discectomy and fusion, it's usually a one-night stay in the hospital, and they recover over about 6 weeks' time. A microdecompression and microdiscectomy is about 0 to 1 night stay, so they may go home the same day, and about 4 weeks in terms of recovery. A lumbar fusion is usually 1 to 2 nights and about 8 weeks of recovery. And I will say that the majority of our patients do go home in 1 night as they are doing very well, and they are able to go home because they have their pain appropriately controlled, they do well with physical therapy, and they're ready to go home. So we do have offices actually in 3 different areas, but in Santa Rosa, it's at just right across the street from Memorial Hospital, and at Sutter, we are just next door in the medical office building. So that's where I'm going to go ahead and end things and start answering questions.
Well, great. Thank you, Dr. Athanassious. That was terrific. We do have some questions, and I also want to remind people that even while we're answering questions, you can still ask questions by going to the little Q&A button at the very bottom, and just clicking it and typing your question. Dr. Athanassious is live and he will answer them right now. So here's the first one. Does a compression in the mid-thoracic region cause breathing problems?
It can cause breathing problems at two different points. So at the time of the injury, it can cause a great deal of pain because as you inhale, it's moving the thoracic bone. It can also cause problems if the fracture occurs at multiple different levels and the patient falls more into kyphosis or falls forward, because a person would not be able to open up their thoracic cavity and would not be able to take in a breath.
Great. And you could stop sharing your screen now and we'll see your there you go. The next question is, can a pinched nerve in the neck cause numbness in the hands?
For sure, yes. A pinched nerve in the neck can cause numbness in the hand. Additionally, a numbness in the hand can be caused from a problem in the elbow or a problem in the wrist. If you think about a nerve like a water pipe, sometimes patients can have compression in the neck, also in the elbow or wrist, and we call that a double hit phenomenon. So certainly a compression in the neck, depending on where it is in the neck, can cause numbness in certain aspects of the hand. And if you look up a dermatomal map on Google, you can see those regions and get an idea, maybe where your pathology is even coming from. Or you can just come see me.
Great. All right, next question is, can you tell me if you recommend nerve ablation to relieve pain?
So it really depends on the type of pain that you're experiencing. If you have pain that's only in the back region, it could very well be what would be beneficial in terms of your treatment. I would encourage you to come in and see me so that I can take a look, because sometimes nerve ablation treats the facet joint, and the facet joint is not what's causing the pain.
Great. All right, our next question is, I have weakness and discomfort in my thigh if I stand still in one place for any length of time, but walking almost immediately resolves this weakness and discomfort. Could this be a spine issue?
Yes, it could be. This can be an issue of spinal stenosis within the spine. Sometimes what happens is when patients try to stand on their own, they're standing up and they have their back arched. They go to walk and they flex forward in order to make more space in their spinal canal, and that allows them to have some relief. So I'd encourage you to come in and we could take a look.
Great. All right, the next question is, I have arthritis with clicking noises in my back and neck. What could be the cause of this and what's the possible treatment?
So the causes can be the arthritis that we spoke about, the disc disease that we spoke about. There's many different treatments. I would have to take a look at your x-rays, your MRI, or your CT scan to get a good idea. Also, it really depends where you are in your treatment. If someone comes in and they say, hey, this back pain bothers me, it bothers me towards the end of the day, I have not done anything for it so far, we start at a different point than somebody that says, I've seen a physical therapist, I went to the chiropractic doctor, and it's not any better, it's in fact worse.
Okay, great. And we'll remind people if they fill out the form, they can come see you. All right, let me see if I can get this one right. I had an ACDF in 2016, resulting in a non-union as well as a crack in my graft fusion. I have developed spurs in adjacent discs and feel pain as a result. What are my options at this point?
So your options are a thorough evaluation to see if there continues to be a problem with that fusion. That needs to be addressed because that can be a source of your neck pain. The next thing is to look at the other levels and to see, now are those causing compression as well? And is that a cause of your pain?
Okay, thank you. How do you maintain water in the disc?
Unfortunately, we don't have any way of maintaining it ahead of time. It's a genetic thing that goes along with also a person's daily activity. So for instance, a person may have degenerative disc disease from their family history or from a genetic cause. And then maybe they work as a contractor or somebody that drives a truck or or enjoys mountain biking or four-wheel riding. Those combinations of things will accelerate degenerative disc disease. There's not really any medication or anything that can be done ahead of time. It either happens or it doesn't, and we address it when someone presents clinically.
Great, thank you. Next question is, if leg pain is not relieved by a cortisone shot, does that eliminate the lumbar as the cause?
No. It could be that the disease is too far progressed. It could be that the nerve is just too irritated. So it does not eliminate it. It's a very good factor if it worked the other way in terms of a patient having excellent relief of symptoms that lasted for 2 to 3 weeks. That would tell us, hey, that's definitely the pain generator, but it doesn't work the other way around.
Great, thank you. Let me try to get this right. Is retrolisthesis a condition that is helped by surgery?
It is. Not necessarily needing surgery. It's on a case-by-case basis. But retrolisthesis is that opposite of the slip that I showed you. So the slip that I showed you is called a spondylolisthesis or an anteriolisthesis. So that means that the bone's sliding forward. The retrolisthesis means the bone's sliding back. And either way, in either direction, that takes the alignment away from the spine, and that increases the compression which occurs on the nerve.
Great, thank you. Next question is, I have a diagnosis of degenerative scoliosis. I have back pain intermittently depending on my activity level. What do you recommend for this diagnosis?
So most likely I would start with asking and understanding how much it affects you on a daily basis. If it affects you a little bit and you have not had much non-operative forms of treatment, we would probably go that route. It affects you a lot and you've had this treatment, we would have to evaluate it on a case-by-case basis and take a look.
Great. Next question is, does a laminotomy cause instability in your spine?
It can. A laminotomy or a laminectomy can cause instability in the spine. Additionally, a patient can develop instability by natural causes or have a predisposition what their spine looked like previous. For instance, if a person had that anteriorlisthesis or spondylolisthesis, that slippage that we talked about before, but it wasn't mobile, doing a laminectomy in that patient does have an increased risk of developing instability at a later point. It could occur from the surgery or it could occur from a fall. It could occur just from further degeneration of the disc.
Great. A couple more questions. What recommendation do you have for the best exercises for back health? Yoga, Pilates, weights, stretching, or something else?
So what I do is I would encourage being evaluated by a physical therapist, talking to them about your daily activities and having them go through a regimen that works for you. They might actually be able to go through having a mixture of those things depending on what you enjoy doing. It's important that we focus on not only what your symptoms are, what do you enjoy doing, what works for you, and what are you going to stick with? Because these exercises that we want you to do need to be almost routine, like brushing your teeth. Something that you will stick with, enjoy doing, and continue doing for your lifetime.